Okay, welcome back. The next section is going to deal with chronic obstructive pulmonary disease. And the idea here is that these are chronic diseases that obviously affect the lung, and that the key underlying premise in all of these diseases, and there's going to be 4 total, is that we have obstruction. Now, what do we mean by obstruction? It is an obstruction to getting air out of the lung. That's the notion that we have to carry in the back of our mind when we're thinking about these diseases. In each of these disorders, there will be an obstruction to getting air out of the lung. Airway obstruction is the hallmark of these diseases, as I've already highlighted to you. And when you think about airway obstruction, you should recognize that this airway obstruction in the patient is clinically going to manifest with changes in spirometry. Now, spirometry is the way by which we measure lung volumes, and if you go back to normal physiology, you'll recall that there are a series of measurements that we can obtain from spirometry. It's not the purpose of this discussion to go into a detailed talk about spirometry, but what I would like to highlight are the key take-homes that you have to know, especially in the context of disease, from your understanding of spirometry. So let's begin with one idea here, and that is that if we've got airway obstruction and the problem is getting air out of the lung, then the forced vital capacity will go down. What's the forced vital capacity? This is the amount of air that you can blow out when you breathe all the way in and then blow out as much as you can. So it's a maximal expiration. Otherwise stated, if you want to think about it another way, if I asked you to blow out candles on a birthday cake, you would use the FVC. You would breathe in as deeply as possible and then blow out as much as you could. So in this particular set of diseases, because there's obstruction, the forced vital capacity, the amount of air that you could blow out maximally, is going to go down. In addition, what's also going to go down is the FEV1. The FEV1 is the forced expiratory volume, and that's the amount of volume that you can get out in a 1-second period, hence the designation 1. And so this represents the amount of air that comes out of the lung with a forced expiration in the very first second of that expiration. This will also go down, but it will go down more than the forced vital capacity. And that's actually very important to understand, because that translates in a key finding that almost defines the disease, which is that there is a decrease in the FEV1 to FVC ratio. It's probably easier to understand this with a couple numbers, so let's just plug in some numbers to understand what I'm talking about. Let me remind you that your normal forced vital capacity, the normal amount of air that you could blow out in a maximal expiration, is about 5 liters. And that's the normal. Now, of that 5 liters, about 4 liters is what is removed within the first 1 second. So that ratio, 4/5, is about 80%. And that's the normal. Now, let's say that a patient has COPD. Well, obviously, this number is going to go down, and this number is really going to go down, and that's going to change the percentage so that the ratio decreases. For example, in a patient with COPD, we might expect that the forced vital capacity goes down by 1 liter to 4 liters. And we would expect that the FEV1 would significantly decrease from 4 liters to maybe 2 liters. And so now that ratio is 50%. And so these patients have had a decrease in their FEV1 to FVC ratio. And that's a very important high-yield physiology association for COPD. It's very important to be aware of. An additional finding in COPD will be that the total lung capacity will be increased. The total lung capacity is the total amount of air that you can have within the lung at the maximally. And so that total lung capacity is going to be increased because there's going to be air trapping. If you can't get air out of the lung, some air will be trapped in the lung, and so the total amount of air present within the lung maximally will actually increase, and that's the total lung capacity. Generally speaking, if you want to know, if you want to think about this with some numbers, the normal total lung capacity is about 7 liters. And in COPD, it goes up to about 8 liters. So here's some very high-yield physiology tie-in for this particular discussion. Now, the very first of these diseases is called chronic bronchitis. Chronic bronchitis is interesting because it's defined clinically. Basically, the notion is that the patient has a productive cough, and that productive cough lasts at least 3 months over a minimum of 2 years. This cough is so productive that when the patient comes to you, they will tell you that they are coughing up cups of mucus, tons and tons of mucus. Some patients will come to you saying they cough up buckets of mucus. That's how much mucus is produced in these patients. Now the next question would be why? What drives this disease? Basically, it's a smoking-related disease. To understand this, you actually have to understand a little bit of normal histology, so let me take you back one step. Here is the lumen of the bronchus, and this is chronic bronchitis, so it would involve large airways like the bronchus. So this is the lumen of the bronchus, and then you're well aware that the epithelium that lines this region is called respiratory epithelium. And remember that respiratory epithelium is pseudostratified, which means that some nuclei are high and some nuclei are low. And it's called pseudostratified because all the cells really do touch the basement membrane. So that's pseudostratified. Columnar, the cells are tall. Ciliated, the cells have cilia. Epithelium. And again, all of these cells sit on a basement membrane, and that's the epithelium. Underneath that epithelium is a lamina propria. And recall that in the lamina propria you have very large caliber blood vessels, venules basically. And these venules, they bring warm blood into the region, which then allows the air to be warmed before it goes down to the bottom of the lung for exchange. And so that's the lamina propria. And then underneath the lamina propria you have something called the submucosa. And remember that the submucosa contains glands, and there's two types of glands. One gland is called the serous gland, and that serous gland produces watery fluid that helps to humidify the air. The watery fluid goes up here and then humidifies the air before it goes down into the lung. And of course the purpose of humidifying the air is that you don't want to turn the lung into a dry sponge. At the same time, there are mucinous glands, and the mucinous glands produce mucus-like fluid, which then goes and lines the epithelial surface, and that mucousy fluid acts as a filter for particles as you're breathing in, because you don't want the pollution and junk from the outside air to actually come down into the lung. So that's the purpose of the mucinous glands. And then, of course, underneath the submucosa in a large airway like the bronchus would be cartilage. Now, let me just remind you that normally the ratio of these glands here to the entire thickness of the wall is less than 40%, i.e., basically the mucinous glands take up about 40% or less of the thickness of the wall. Now let's imagine that there's a patient that smokes. If they smoke, they're going to be bringing in a ton of pollutants, a ton of foreign particles into their lung. And in response, the lung is going to try to respond to deal with all of that foreign material by increasing the amount of mucus produced. So if you need to increase the amount of mucus produced, you're going to undergo hyperplasia and hypertrophy of these mucinous glands. So as we get excess mucinous glands because of the smoking, then these excess mucinous glands are going to take over. Why don't we say this? The excess mucinous glands are going to increase in thickness relative to the overall thickness of the wall, and so the mucinous glands, their thickness will become greater than 50% of the overall wall. And that's important because that's called the Reed index. The Reed index measures the thickness of the mucinous glands relative to the entire thickness of the wall, and in chronic bronchitis it becomes greater than 50%. Now what's also important to note is that if we've got all of these mucinous glands and they're producing a ton of mucus, guess where all that mucus is going to go? Into the lumen. And guess how the patient's going to get rid of it? Well, some of it is going to be coughed up, which is then going to create the chronic bronchitis with the productive cough that lasts at least 3 months over a minimum of 2 years. And at the same time, some of the mucus is also going to go back and it's going to plug the airways. And when it plugs the airways, there's going to be trapping and there's going to be an obstruction to getting air out of the lung. With all of that background, now you can understand the disease. So what did I say? I told you that it is highly associated with smoking. That should make sense. At the same time, I tell you in your text, and go back and read the text now, there's hypertrophy of the bronchial mucinous glands. This increases the thickness of the mucus glands relative to the overall bronchial wall thickness, and the Reed index becomes greater than 50%. Again, normally it should be less than 40%. Let's illustrate that again with a real histologic image. What I've tried to do in this image is I've tried to capture the entire wall thickness. So we start up here at the very top. That's the respiratory epithelium in the upper right-hand side of this slide. This is sitting on a basement membrane. Underneath the basement membrane is a lamina propria, which contains dilated venules, which basically bring in warm blood in order to humidify the air. These are the mucinous glands from here all the way here, and you can see all these little circular spaces that are lined by mucinous cells, and these cells basically produce mucus, which goes up and then goes out into the luminal space. Now, it's important to note that normally the thickness of these mucinous glands should be about 40% or less of the entire wall thickness. Here's the cartilage down here. If I look at this entire wall thickness up here, and I ask you a simple question, what percentage of that thickness is taken over by the mucinous glands? I think you would agree with me that it's certainly greater than 50%. And so greater than 50% thickness of the mucinous glands is an increase in the Reed index, which is one of the classic findings in chronic bronchitis. Now, these patients with chronic bronchitis are going to present with a productive cough, but that makes sense because they're making a ton of mucus, and that ton of mucus is going to come out as a cough. So that's a classic clinical feature, and there's no rocket science here. Another important finding is that they're going to get an increase in the PaCO2 and a decrease in the PaO2, and that's going to present a cyanosis or blue discoloration in the patient. Now, in order to understand that, we can probably go back a step and remind ourselves that the goal of the lung is to generate a partial pressure of oxygen in this alveolar airspace, a P big AO2, and that P big AO2 produces a pressure that squeezes oxygen into the blood vessels, and when it squeezes oxygen into the blood vessels, that creates a P small AO2 within these blood vessels. So that's the normal. Now, of course, you don't want to have carbon dioxide, or as soon as you pick up any carbon dioxide in the alveolar space, you don't want to keep it there, you want to blow it out, because there is a limit to the amount of pressure that you can generate within this region, and you want all of that pressure to be pressure of oxygen. If you start putting carbon dioxide here so that you now generate a PaCO2 that's significant, that increase in PaCO2 will automatically decrease the PaO2. And that decrease in PaO2 will mean that there's less pressure to squeeze the oxygen across that barrier into the blood, and so the P small AO2 will also decrease. And so basically this is the summary of what's going to happen lab-wise. The P big ACO2 will go up along with the P small ACO2, and the P big AO2 will go down along with the P small AO2. So that's the summary of how the patients become cyanotic and why they get these particular lab findings. Another important thing to be familiar with is that there's an increased risk of infection. Here's a general pathology principle. Anytime you have a tube and you block it, you're going to get an infection behind that block. So for example, patients who have BPH, they're not able to get urine out very well, and so the urine piles up in the bladder, and there's an increased risk of bladder infection in those patients. Similarly here, if you've got airways, and you can imagine that the airways, as they branch, if there's mucus plugging, you're going to get infection behind that block. And so there's an increased risk of infection in these patients. And the final thing to be aware of is that there's a risk of cor pulmonale in these patients. So what's cor pulmonale? That requires a little bit of understanding of physiology. Now recall that the blood vessels in the lung, they are designed to recognize that if there is a lack of oxygen in a particular region of the lung, that they should actually clamp down to shut down that region and instead shunt the blood in another direction. Let's just take a simple example. Let's say a patient has pneumonia. It's in the, the left upper lobe. If they've got a left upper lobe pneumonia, there's really not much oxygen getting in there because the lung is basically loaded with pus and inflammatory debris. So in response, what the capillaries of the alveolar air sacs do, actually this happens at the level of the arterioles, but what the arterioles do is they squeeze down to decrease the amount of blood going to the left upper lobe, and instead blood will be shunted to other parts of the lung with the hope that that blood will be able to meet oxygen and to be able to carry out the exchange that is the purpose of the lung. So that makes sense, and that's very good, because if I've got an upper lobe pneumonia in the left lobe, I don't want my blood going there looking for oxygen, and instead I'd like to send it to another part of the lung. But imagine that if you have a disease where you're not oxygenating properly, and so you start clamping down, and every area of the lung clamps down thinking that blood should go to another part of the lung, not knowing that there's disease in another part of the lung. Everybody's clamping down and trying to send the blood in a different direction, but there's disease throughout the entire lung. So that's a problem, and all of that clamping down of the blood vessels has to be dealt with by the right heart. The right heart's going to have to pump against all of that high blood pressure, and so that's going to result in initially right ventricular hypertrophy, and eventually the patients will fail the right heart, and that's called cor pulmonale. So that's a very high yield sort of paradigm to be familiar with. So emphysema is the next of the chronic obstructive pulmonary diseases, and in this particular case there's destruction of the alveolar air sacs. Now remember from your normal histology that the lung is sort of like an upside down tree. So that if this is the main stem bronchus, and then the bronchus kind of branches off into these bronchioles, and eventually the bronchioles branch off into terminal bronchioles, and eventually you produce these little alveolar air sacs, which is where the exchange occurs. Now, I call it an upside down tree because this is sort of the trunk up here, and then you've got all these branches, and eventually the leaves are like the air sacs. They're sort of tiny little leaves at the very tips of the branches. And so what happens in emphysema is that you get destruction of these alveolar air sacs, and as you get destruction of the alveolar air sacs, that results in a chronic obstructive pulmonary disease. Now you could ask the question, for example, you could stop me here and you could say, well, what are you talking about? You said that these are obstructive diseases. I don't see any obstruction in this disease. That's true. You don't see any anatomic obstruction, and you don't really see any mucus plugging or anything of that nature which would create an obstruction. But the obstruction here is a little more physiologic. And that's going to be important to understand because it ties into a few high-yield principles. So let me remind you of a couple things. First of all, what's happening in this disease is you've got, you've got all these alveolar air sacs at the very distal portion of the lung, and these alveolar air sacs are like tiny balloons. They fill up with air, and as soon as they fill up with air, they immediately snap back due to their elastic recoil, and then they blow the air out. So you breathe in, and you fill up the balloon, and then you relax, and then the air is squeezed out. So first of all, imagine if we lost this elastic recoil because we destroyed some of the walls of the lung, then instead of having a bunch of little balloons, what we'd really have is one big shopping bag. And that shopping bag is not going to have good elastic recoil, and so you're not going to be able to get air out of the lung very well. Just take a simple example. If I gave you a balloon and asked you to blow it up, and then you let go of it, it's going to shoot air back in your face. But if I give you a shopping bag and blow it up, and then ask you to let go of it, air is not going to shoot back in your face. So instead of having a bunch of little balloons, it's as if the lung develops a bunch of big shopping bags. So that's one reason why they're not able to get air out, i.e. they're obstructed from getting air out. A second reason why they're obstructed from getting air out is the following. And this requires a little bit of physiology. So let me take you back a step and just remind you. The lung is an upside-down tree, and you've got this main stem bronchus, and then you've got all of these branches, and then you've sort of got all these little balloons. Now, as you got millions and millions of these air sacs, and as you breathe out, you're going to accelerate air up through this system. And as you accelerate air up through this system, you're really going to kind of narrow the number of tubes so that eventually you shoot all the air through one large caliber conducting airway. Now that, as you're blowing all that air through, that creates a significant amount of acceleration of the air. And you can imagine that as air is being shot out this way, it's also going to drag on the wall of the tube. And when it drags on the wall of the tube, there's going to be a tendency to cause that tube to collapse. Now up here in the larger airways, you have cartilage in the wall. And the reason for having cartilage in the wall is because you want that airway to be able to remain open when you're breathing out and accelerating air across that tube. So the cartilage helps to keep that wall open as air is shooting up out through it. Again, you don't want that wall to collapse. Now down here, remember that the defining distinction between a bronchus and a bronchiole is a lack of cartilage. There's no cartilage in the bronchioles. The bronchioles, instead, the way they stay open is that there are a bunch of alveolar air sacs, for example, here and here. Why don't I clear this and draw this again? This is a bronchiole now, and the way the bronchiole stays open is that you've got these air sacs, and the air sacs have elastic recoil, and that elastic recoil actually pulls open these walls. Now, normally when I breathe out, I'm going to accelerate air across this tube. And when I accelerate air across this tube, I'm going to actually create a force on the wall of the tube that's going to suck that tube closed. However, these air sacs are going to keep that tube open because they have elastic recoil and they're pulling at the tube, keeping it open. Let's imagine that I destroy these walls so that now I don't have that elastic recoil. Well, when I lose that elastic recoil, as I shoot air up this way, I'm going to actually drag the wall along with it, and when I drag the wall along with it, boom, this wall is going to close. And when this wall closes, that's going to result in obstruction. This is a very high yield principle to understand because it goes back to normal physiology, it ties in a little bit of histology, and it also reminds you of the reason why there's obstruction. Basically, the patients, they get collapse of the small airways due to loss of the elastic recoil of the alveolar air sacs. Now let's go back and read together. So what do I say? I say that emphysema is a destruction of the alveolar air sacs. There's loss of elastic recoil and collapse of the small airways, and this leads to air trapping. So I've already explained that. Here's what a picture of emphysema looks like, but here you can clearly see that you're seeing all these spongy holes within the lung, and that's because those normal little tiny balloons have been converted to quote-unquote shopping bags. And so this spongy appearance to the lung, this porous spongy appearance, is classic for emphysema. Now, going one step further, we can look at this histologically and we'll see the same process. Let's just take, for example, here, the bottom left-hand corner of the screen. Let's say that that's a normal air sac. So there are a few rare normal air sacs in this picture. Now look at these air sacs. These are way too dilated. These are huge dilated air sacs, and that's because we've lost alveolar air sac, and so we've converted those tiny balloons into shopping bags. So why does this occur? Why do patients get emphysema? And to understand this, you have to recognize that in emphysema, there's an imbalance between proteases and antiproteases. That's what really causes the disease. So what does that mean? Let me just remind you that every time we breathe in, most of what we breathe in from the outside world is being filtered by the lung, particularly the mucus within the lung, and that allows us to keep whatever goes down into the very distal portions of the lung clean. Now, when you get to the bottom of the lung, you don't have those defense mechanisms. So the only way by which we can defend ourselves at the very bottom of the lung is a cell called the alveolar macrophage. It sort of eats things that might happen to get way down at the very bottom of the lung. It's not common for particles to get down there, but it is possible. Now, on occasion, there will be some things that will come down to that part of the lung. The macrophages will eat them, and when the macrophages eat them, that induces a little bit of inflammation. So otherwise stated, it's common to have some degree of inflammation present within the alveolar air sacs. Now, that little bit of inflammation in the alveolar air sacs is going to produce proteases. That's a byproduct of inflammation. That would be damaging to the lung. But the body produces a protein that protects against proteases, and those are called the antiproteases, the most important of which is one called alpha-1 antitrypsin. So otherwise stated, we constantly have a small level of inflammation ongoing within the alveolar air sacs. That small level of inflammation results in the production of proteases, which are a byproduct of inflammation, causing tissue damage. In order to protect ourselves against those proteases, we have antiproteases, the most important of which is alpha-1 antitrypsin. Now, this normally exists in a balance, so that the proteases and the antiproteases are present in balance, so that whatever proteases are produced, we have enough antiproteases to handle those. In emphysema, the problem is either an overproduction of proteases or a decreased production of antiproteases. Now, there's basically two classic diseases that give you emphysema, and each one covers a particular aspect of this paradigm. For example, one group of patients, and the most common group of patients to develop emphysema, are those that have a tremendous amount of inflammation going on in the distal portions of the lung. And guess who those patients are? Smokers. Smoking is the most common cause of emphysema. Smokers bring a ton of garbage into their lung. There's a ton of protease activity. The protease activity overrides the antiprotease activity, and these patients then develop emphysema because those proteases destroy the alveolar air sacs. So that's one group of patients that develops emphysema. The second group of patients that develop emphysema are those patients, when you consider this balance of proteases and antiproteases, the second group of patients are those patients that have decreased antiproteases. And the classic disease, which is relatively rare clinically, but is very common on examinations, is where patients have an alpha-1 antitrypsin deficiency. Now, if patients don't have good alpha-1 antitrypsin floating around in the blood, then they won't be able to protect against the protease damage that occurs normally. So over time, there's a chance that they could develop emphysema. So that's the second disease that's going to result in emphysema, and that's alpha-1 antitrypsin deficiency. Now let's read together. What do I say in the book? I say smoking is the most common cause of emphysema, that I've already explained, and it results in centri-acinar emphysema, which is more severe in the upper lobes. This requires a little bit of explanation. Now, what is centriacinar emphysema? So why don't I take a step back and remind you that there are two major categories of emphysema. There's a centriacinar emphysema and there's a panacinar emphysema. In order to understand this concept, you need to understand the acinus. So let's go back here and remind ourselves that the functional unit of the lung is called the acinus. Remember that we get a terminal bronchiole, and the terminal bronchiole eventually opens up into the alveolar air sacs. So this is sort of the functional unit of the lung. This whole thing that I'm outlining here, that's called the acinus. Now let's pretend that a patient is a smoker, so that, the smoke is coming down this central airway, eventually branches and comes into the terminal bronchiole. Obviously there would be multiple branches here, I'm just simplifying this image. Eventually comes into the terminal bronchiole and then hits the acinus. Let me ask you a very simple question. Which part of this acinus is going to be most hit by the smoke? Of course, the central part of the acinus. And so guess what type of emphysema smokers are going to get? Centriacinar emphysema. Very easy. And of course the other one is called panacinar, and panacinar means that you disrupt the entire acinus, and the patients who get panacinar emphysema are those who are alpha-1 antitrypsin deficient. But the way I remember this, I only remember the smoking related is centriacinar because it makes sense to me, and then I know the other one is panacinar, and so I associate that with alpha-1 antitrypsin. Now one more important principle, and that is that patients who smoke, not only do they get centriacinar emphysema, but it's also more severe in the upper lobes. But again, there's no rocket science here. If I give you a match and I blow it out, which way is the smoke going to go? It's going to go up, obviously. And so when a patient smokes, guess which way the smoke's going to go when it goes in the lung? It's going to go up. It's one way to remember this, right? So these patients are going to get centriacinar emphysema that's more severe in the upper lobes. So that should be now fairly easy to understand, and let's read together. I say that smoking is the most common cause of emphysema. It results in centriacinar emphysema that is more severe in the upper lobes. Then I say in your text that alpha-1 antitrypsin deficiency is a rare cause of emphysema. It results in panacinar emphysema, more common in the lower lobes. Again, it's opposite of smoking. We're going to see it more commonly in the lower lobes. Now here's one more point to be discussed, and that's that patients who have alpha-1 antitrypsin deficiency may also develop liver cirrhosis. What I want to remind you is that in alpha-1 antitrypsin deficiency, the deficiency is that the protein is not in the blood. However, the liver is still making the protein. And what happens in this particular disease is that alpha-1 antitrypsin is produced by the liver, but the mutation results in a misfolding of the protein so that the protein begins to accumulate within the endoplasmic reticulum of hepatocytes. And when it accumulates within the endoplasmic reticulum of hepatocytes, it begins to pile up in the liver cells and eventually damages the cells, resulting in cirrhosis. And that's why liver cirrhosis may be present. And here's the high-yield way by which examiners like to ask this. So these are all hepatocytes. This is a biopsy of the liver. And you can clearly see that, for example, in this hepatocyte, there are these round purple or pink colored globules. And so these purple or pink colored globules, these actually represent alpha-1 antitrypsin that's building up in the hepatocyte. Very high yield picture for examinations. What I'd like to also remind you of is that these globules, they are PAS positive. PAS is a special stain that we use in histology, and they're PAS positive, and examiners like you to know that as well. So pink PAS positive globules. And that's all of the key summaries for this particular slide. Now, one more thing that we have to be familiar with, and that is the genetics behind alpha-1 antitrypsin deficiency. Let me remind you that alpha-1 antitrypsin gene comes in multiple alleles. The most common allele or subtype is called PIM, so that most patients actually have PIM and then another copy of PIM. And most people are actually possessing this allele, and this is the normal allele, and so there's no problem. The mutations are multiple. There are many, many, many mutations. However, the most common clinical mutation to be aware of is the PiZ allele. PiZ is going to result in a mutation such that you get malformation or misfolding of the protein, I should say, and the protein is going to accumulate in the endoplasmic reticulum. All right, board point, endoplasmic reticulum. Now, one possibility is that the patients could be heterozygotes. They could have one normal allele, the M allele, and one abnormal allele, the Z allele. These patients are usually asymptomatic, but there will be a decreased circulating level of alpha-1 antitrypsin. That's because they're only producing half of the normal. These patients usually are fine. However, if the patient smokes, there's a really high risk for the development of emphysema. And so the way by which we would treat these patients is to make sure that they don't smoke. So that's the PIMZ heterozygote. Now, it's also possible for a patient to have PIZZ, i.e. they're homozygous for the mutation. If they're homozygous for the mutation, these are the classic patients who get pan-acinar emphysema and cirrhosis. So this is the classic patient who's going to get pan-acinar emphysema plus cirrhosis. And I've already explained the cirrhosis to you. Now, clinically, the features are going to be the following. The patients will have dyspnea, shortness of breath. They're going to have cough, but they won't produce sputum. This is not chronic bronchitis, so they're not going to be coughing up a ton of mucus. The patients are going to have prolonged expiration with pursed lips. This is very, very, very high yield. So again, when you think about this, if this is a small airway, and you know that the problem is that they lost the elastic recoil that was holding this airway open because of the emphysema, so that now when they accelerate air, they're also going to be dragging this wall, and this wall is going to collapse shut. Imagine if the patient is creating pursed lips so that they increase the back pressure from above, then that's going to create a little bit of back pressure here, and that back pressure is going to force these walls open. So by creating a little bit of back pressure and forcing the walls open, the patient will then be able to get air out, albeit slowly, but they'll at least be able to get air out. And so what these patients do clinically is that they prolong their expiration and they purse their lips so that they generate a little bit of back pressure, which will then allow air to be able to move in and out. And so they can maintain their oxygenation, but they have to breathe in this funny way. And so that's why they're called pink puffers. They stay pink because they're oxygenating, because they can overcome that obstruction, but they have that particular pursed lip appearance. Now, of course, this requires a tremendous amount of work. They've got to breathe slowly and breathe in a very mechanical way, or in a very particular way, and that requires basically exercise, and so they lose weight. And classically, you'll recall that these patients, they're very, very thin. And then the final change that we're going to see in these patients is that there's going to be an increased AP diameter of the chest. This is super high yield as well. Let me remind you from normal physiology that the tendency of the lung is to collapse in. The alveoli have elastic recoil and they would like to collapse in. And the tendency of the chest wall is to expand out. And so normally the collapsing in tendency of the lung is in balance with the expanding out desire of the chest wall. Now, do you know at what point those two meet? So there's two curves, and those two curves meet at a particular point, which board examiners love to ask you. What's that set point called? That set point is called the functional residual capacity, or the FRC. Imagine if a patient has emphysema. They've lost the elastic recoil of the lung, correct? So now the chest wall is going to win that tug of war, and it's going to be able to expand out a little more. And when it expands out a little more, that's going to increase the AP diameter of the chest. And so this is a classic finding in patients with emphysema, that they have an increased AP diameter of the chest. Now let me remind you, because examiners will ask you this, trying to tie in a little bit of physiology, that when you lose this elastic recoil of the lung and the chest goes out a little bit, you're going to reset the FRC, or the functional residual capacity, so that the FRC will now be increased. Similarly, I'll just give you another example because it's a board point and it comes up, it's a derivative of this discussion. If I had fibrosis of the lung, I would increase the elastic recoil of the lung, and therefore I would actually pull the chest wall in a little bit, and that would decrease, for example, the FRC, or the functional residual capacity. Here's a picture of barrel chesting. You can clearly see that this sort of looks like a barrel. But most importantly, you've got an increase in the AP diameter of the chest. A few late complications of emphysema. The first is hypoxemia. Now basically these are pink puffers, and they're able to maintain gas exchange appropriately because they keep their lips pursed and they breathe slowly with prolonged expiration. However, eventually, imagine if these are all the air sacs and we're destroying these air sacs, what's going to eventually happen is not only are you losing the air sacs in the recoil, but you're also losing the capillaries that are present within the wall of these air sacs. So over time, as you lose the capillaries, you're going to lose your the bed across which you're having oxygen exchange occur. And so these patients will become hypoxemic, which means that they won't be able to generate a good PaO2. Remember that hypoxemia has a PaO2 less than 60. Okay, so that's going to be a problem. And then, of course, another problem, as I've already discussed, is eventually if they get hypoxemia, then the blood vessels are going to constrict. And as the blood vessels constrict, the right heart is going to have to pump against those blood vessels. And when the right heart pumps against those blood vessels, it'll first undergo hypertrophy, but then eventually it'll undergo failure, and that's called cor pulmonale. I've already explained this previously. All right, so the next of the COPDs is asthma. And what I'd like to say about asthma is that this is a chronic obstructive pulmonary disease because you get airway bronchoconstriction. We're all familiar with asthma. We recognize that this is the key feature of the disease. Of course, this is reversible, and of course, what induces the asthmatic attack is usually exposure to an allergic stimulus, resulting in a type 1 hypersensitivity reaction. Now, asthma presents in childhood, and it's most often associated with other types of allergic conditions like allergic rhinitis, eczema, and often there's a family history of these types of atopic reactions. The pathogenesis of the disease is that the patient gets exposed. Now, this is going to be a genetically susceptible patient, all right? So some patient that's got a family history and carries a set of genes that are going to make them susceptible to the development of asthma. Now, this patient, they get exposed to an allergen. That allergen induces the Th2 phenotype in CD4 positive T cells, which then results in the T cells secreting IL-4, IL-5, and IL-10. Remember that you need to know, for examination purposes, that the classic cytokines produced by the Th2 helper cells subtype is IL-4, 5, and 10. So 4, 5, 10. That's what I remember. Now, when I think about IL-4, you need to know what it does. And the key thing that it's going to do is it is going to allow the plasma cell to class switch to IgE. So it allows for the production of IgE. And that IgE is going to be important because this is an allergic reaction, as we're well aware of, and IgE is going to mediate it, as we're going to talk about on the next slide. You need to know that IL-5 is important for calling in eosinophils. This is all over examinations. IL-5 calls in eosinophils. So that's important to know. Now, what does IL-10 do? Well, IL-10, it has the ability to inhibit the production of Th1 helper T cells and instead to induce the production of Th2 helper T cells. So basically, it helps to promote this overall reaction. So IL-10, again, it stimulates Th2 subtype of helper T cells and inhibits the Th1 subtype of helper T cells. Now, these patients, what will happen eventually is that they will get re-exposed to the allergen. And when they get re-exposed to the allergen, remember that these are the patient's mast cells, and the mast cells are going to have surface IgE, and the allergen is going to cross-link that surface IgE so that when surface IgE molecules get cross-linked, that's going to activate the mast cell. Very high yield to know for the purposes of board examination what exactly is going to happen when the mast cell is activated. So when the mast cell is activated, the very first thing that it does is it dumps preformed histamine granules. Those are released. Remember from immunology and from an earlier chapter in our discussion that when you release those preformed histamine granules, that's going to result in histamine-induced vasodilation and histamine-induced increased vascular permeability. Again, high yield for examination. Let me ask you one more question since we're on the topic. The histamine-induced vasodilation, remember where does that occur? At the arterioles. And the leaking of fluid, where does that occur? In the postcapillary venule. All right, that's high yield to be familiar with, but I've already taught you that in the inflammation lecture. So anyway, the first step is the activation of the mast cells, and that's going to result in dumping of histamine initially. Now the mast cells then have a second phase by which they perpetuate inflammation. Very high yield to know. The second phase by which they perpetuate inflammation is production of leukotrienes C4, D4, and E4. Now remember that leukotriene C4, D4, and E4, they do a couple things. Number one, they cause vasoconstriction. They constrict the smooth muscle of the blood vessels. They cause increased vascular permeability by constricting the pericytes. and they cause bronchoconstriction by constricting the smooth muscle of the bronchus. And if you go back to your inflammation lectures, I summarized how leukotrienes work in a very simple way, and hopefully you'll keep that in the back of your mind. Anyway, the point is that the dumping of leukotrienes C4, D4, and E4, which again is an arachidonic acid metabolite, will eventually result in bronchoconstriction. So that is going to be the very first phase, which is the activation of the mast cells is then going to result in bronchoconstriction. Now, over time, what's going to happen is that the tissue damage and the inflammation and the presence of inflammatory mediators like major basic protein from the eosinophils is going to perpetuate bronchoconstriction, and that's the late phase of the asthma. That's the late phase of the bronchoconstriction. Clinically, these patients are going to present with dyspnea and wheezing. All right, maybe I should take a step back and remind you that the clinical features are episodic. They're basically in relation to exposure to the antigen or the allergic stimulus, and it's going to result in the classic findings of shortness of breath and wheezing. The patient's cough, it's a productive cough, and remember that the productive cough contains these spirals within the mucus called Kirschmann spirals, and maybe even more important and more high yield than that is that within the mucus you're going to find Charcot-Leyden crystals. Charcot-Leyden crystals are crystalline aggregates of eosinophil major basic protein, and it's those crystalline aggregates that can show up in the mucus, and they're called Charcot-Leyden crystals, and it's a relatively high yield concept, and I'll show you a picture in just a moment. Now, the last thing I would like to say is that sometimes patients can get such a severe attack that the bronchoconstriction will not relieve itself, and that severe attack can actually result in something called status asthmaticus, which is the sort of the most extreme form of asthma, which can eventually result in death. Now, here is a classic picture of an asthmatic's productive cough. So this is the material coughed up, put on a slide. And we can clearly see that there are these crystals called Charcot-Leyden crystals, which again are derived from eosinophils. And examiners love to show pictures like this. The last thing I should say about asthma is that there are also some non-allergic causes of asthma. For example, exercise. Some patients will say that exercise gives them asthma. Other patients might say that a viral infection would give them asthma. Some patients will say that when they go to work, they get exposed to certain dust, and that causes asthma. So these are some other causes of asthma. Asthma is not always allergic. One very high yield cause of asthma to be familiar with is aspirin. Now let me remind you that there are a subset of patients, I think it's like 10 to 15% of adult patients with asthma, who have something called aspirin intolerant asthma. So they have asthma, and that's the first part of the triad, but they also have this funny thing where they actually get bronchospasm. So that's a second feature of this disease. It's aspirin-induced bronchospasm. And the third feature is nasal polyps, and that's an interesting feature also seen in aspirin-intolerant asthma. Let's just talk about nasal polyps for a second. Nasal polyps, when you think about them, remember from earlier in this chapter that you classically see a nasal polyp in a patient with chronic rhinitis, which is inflammation of the sinonasal mucosa. However, there are some other high-yield associations with nasal polyp. For example, an adult with nasal polyp with asthma-like symptoms, you think about aspirin-intolerant asthma. So that's one important association. Another very high-yield association is that if you have a child, like a 2-year-old with nasal polyps, what do you have to think about? Cystic fibrosis. That's high yield. Patients actually who have nasal polyps need to be tested for cystic fibrosis at that age. So that's another important thing to be aware of. Anyway, that concludes our discussion of asthma. Now the fourth and final COPD is actually bronchiectasis. What is bronchiectasis? This is a dilatation of the bronchioles and the bronchi. So these are the larger airways. And it's a loss of tone that results in air trapping. Again, let's explain. What happens in this particular disease is that the patient has an airway. This is the normal. And when you have these airways, the problem in bronchiectasis is going to be that you get abnormal dilation of the airway. Now, when there's abnormal dilation of these large airways, that results in loss of airway tone and air trapping. Perhaps the easiest way to understand this is if I gave you a straw and I asked you to blow through the straw and I put my hand on the other side, I would clearly be able to feel the air coming out. If I gave you a pipe bigger than the size of your face, and I asked you to blow out, I would not feel any air coming out the other side. And that's because as air would be accelerated, it would begin to sort of just whirl around in this tube and wouldn't be able to be accelerated out towards the other end. And that's exactly what happens in bronchiectasis. This dilatation of these airways results in loss of tone, and that then results in air trapping, so that when these patients blow out, they can't get air out appropriately. They're obstructed from emptying the lung. Here's a classic image of bronchiectasis, and the idea here is the following. When you look at the lung, you normally should see some larger airways in the center of the lung because that's where the large airways are. However, when you come out to the periphery, here is normal, you don't see those large airways. Here is where the bronchiectasis is, and notice that at the edge of the lung, I'm seeing these large dilated circular air spaces. So that is classic bronchiectasis. The next question is, why do we get this dilatation of the airways? And the answer is it's usually due to necrotizing inflammation with damage to the airway wall. So for example, this will occur in patients who have some reason to have chronic inflammation and infection within the airway, which is then going to result in damage to the wall, which then dilates the airway. Classic example, cystic fibrosis. You know that in cystic fibrosis, patients have thick secretions. The thick secretions cause mucus plugging. The mucus plugging increases the risk of infection because you've blocked a tube. And when you get infection, you're going to get damage to the airway. And so eventually you're going to get bronchiectasis. And cystic fibrosis patients classically have bronchiectasis. Another case where we might see this is Cartaginer syndrome. In Cartaginer syndrome, the idea here is that you have a defect in what? I think every medical student's usually able to say cilia, but you need to take it one step further. What part of the cilia is defective? Okay, it's the Dianon arm. The Dianon arm, which is one component of the cilia, is defective, and that is necessary for ciliary movement. So that's Cartaginer syndrome. Now, what would be the symptoms of this? You get sinusitis because the cilia of the respiratory epithelium in the sinuses is not functioning properly, so you get inflammation there. The patients get infertility because the cilia of the sperm is not functioning properly. They get something called situs inversus, which is where the organs that are normally present on one side of the thorax are on the opposite side. So for example, the heart, instead of being on the left, is on the right side. So that's Cartaginer syndrome. At the same time, they're going to get inflammation and infection within the lung. And that's because they don't have the cilia to pump the mucus out of the lung, to clear the lung, and so therefore there's going to be an increased risk of infection and inflammation. So that's a second classic patient who might get bronchiectasis. A third patient would be tumor or foreign body. Here's the airways. Here's another airway. If there's a foreign body in the airway, that's going to result in inflammation and infection down here. If there's a block because there's a tumor, so that compresses the airway, that would also increase the risk of infection and inflammation. Any type of necrotizing infection, if the patient gets infected with a bug that is particularly necrotizing and virulent, that could result in bronchiectasis. And finally, something called allergic bronchopulmonary aspergillosis. Okay, allergic tells us that this is a hypersensitivity reaction. Bronchopulmonary tells us that it's in the relatively large airways, the larger airways, and aspergillus implies that it's due to aspergillus. Now basically this is a hypersensitivity reaction to aspergillus. It is seen classically in two patients. Do you know which two patients? It's seen in asthmatics and it's seen in patients with cystic fibrosis. And these patients become hypersensitive to aspergillus. When the aspergillus comes in from the outside environment, it elicits this reaction, which then damages the airways, resulting in a bronchiectasis due to the inflammatory damage to the airway. So that's ABPA, allergic bronchopulmonary aspergillosis. Clinically, these patients are going to have cough because, again, these large airways are going to result in this dilatation of the large airways is also going to result in some mucus trapping, so they'll cough up that mucus. They'll have dyspnea, difficulty breathing, and foul-smelling sputum. Now that sputum that comes out is going to be loaded with inflammatory junk and will have been sitting in the lung for a while and rotting, so it'll smell very bad. Complications include hypoxemia. There's going to be trapping of carbon dioxide. Eventually the patients will get hypoxemia, and a complication of that would be cor pulmonale. I've already covered that. What's important to note here is that these patients can also develop a secondary amyloidosis, very high yield for exams. Can we remind ourselves for a moment? Just go back and let's do a quick global review. Amyloidosis refers to the deposition of a misfolded protein. That's point one. Point two, amyloidosis can be localized or systemic. Localized means that the amyloid deposits in one organ. Systemic means that the amyloid deposits in multiple organs. Now, if the amyloid deposits in multiple organs, i.e. systemic, it can be primary or secondary. In primary amyloidosis, you have a deposition of amyloid light chain due to some sort of plasma cell problem. The plasma cells overproduce light chain, it goes into the blood, it deposits in tissues as amyloid. In secondary amyloidosis, you have chronic inflammation, which produces an acute phase reactant called SAA. That's overproduced in chronic inflammation. That overproduction of SAA gets converted to AA, and it's AA that deposits as amyloid, and that's called secondary amyloidosis. So these patients would have secondary amyloidosis with deposition of AA amyloid. And that concludes our section on COPD. Very high yield, a lot of physiology, but very important to be aware of these diseases.